30 years I've been learning, and still, we are not even touched or scratched the base of it, because it's such a vast subject. It is not about just learning surgery, much more than that. Understanding the multidisciplinary component, chemotherapy, radiotherapy, when not to operate, what are the other best modality. So, dear trainees, new trainees, welcome to you. And today we have a fantastic mock exam case presentation on a soft tissue sarcoma, which our DRNB student Devraj Singh is presenting. To discuss that and to take this mock exam, none other than our great Professor Vijay Kumar sir. He is my teacher, everybody's teacher, teacher of teacher. Extremely teaching is so high. His passion to teach is so high that he made his time in spite of his busy official schedule, administrative work, university work, and also operations. So you should learn from him, and sir's approach to the subject and practical is great. You will hear more in coming years in our DRNB, which is very important. And thank you very much and welcome, sir, and thanks for accepting our invitation. And we have Abhijit, who is a dedicated ortho-onco and musculoskeletal, a great guy. I have a very great, passion on this guy youngster, who has done lot of work, lot of publication on this from Ahmedabad. And two of them are going to discuss this. Initially, the candidate will present the case, and as it goes, both of them will interrupt, discuss, and complete it. At the end of the case discussion, they will open the chat box and Q&A and will answer the questions, whatever you have doubts. So please put your questions in the chat box, so it will be answered in the given time. Thank you very much, and over to you, Devraj. Please start the case.
Thank you, sir. Thank you, sir. Myself, Devraj. I am the DNB. I am the DRNB Surgical Oncology resident final year. I am presenting the clinical case on the thigh soft tissue sarcoma. There is a 40-year female residing at Bangalore, housewife by occupation, presenting with the chief complaint of the swelling in the right thigh since 6 months, with mild dilate pain since last 1 month. History of the presenting complaints. Patient was healthy 6 months ago when she noticed swelling in the right thigh, that is the insidious onset and gradually progressed to attain the current size of the approx 18 into 10 centimeter. Pain is the since last 1 month, mild dilate in the nature and non-radiating, insidious in the onset, gradually progressive and relieved by the medications. There is no history of the fever and trauma. There is no history of any redness and ulceration over the overlying the skin. There is no history of any restriction in the movement of neighboring joint. There is no history of any weakness, numbness, and pain in the affected limb. There is no history of the pain in the distal limb on the walking. There is no history of any similar swelling elsewhere in the body. There is no history of any radiation treatment in the past. There is no history of the long-standing edema or swelling in the lower limb. There is no history of the chest pain, dyspnea, cough, and hemoptysis. There is no history of the loss of weight, decreased appetite, jaundice, and abdominal distension. There is no history of the treatment taken and investigation performed previously. There is no history of the bone pain, headache, and neurological deficits. And family history, sir. There is no history of the similar complaints in the family. There is no history of the cancer and cancer-related death in the family. Personal history, she consumes mixed diet, bladder and bowel habits regular. No history of the alcohol and smoking. Past history, past and personal history, sir. No history of any medical illness in the past. Diabetes and hypertension. No history of any previous surgery.
1 second. This is Dr. Vijay.
Yes.
This is going to be in a DRNB surgical oncology. It's going to be a short case.
Yes, sir.
Okay. They are not going to give this as a long case. So for presentation today, it's okay. But you must learn to take the history and present it in a shorter format. What is negative history I'm talking. But coming to this case now, you please sum up and tell me what is the relevant positive and relevant negative history.
Okay, sir. Sir, and the summarize, sir, it's see the 40-year female present with the swelling in the right thigh that insidious on the onset and gradually progressive increasing size in 6 months with mild dull-ache pain since 1 month without history of the any trauma, fever and any comorbidity and any significant family history, sir.
That's all. That is all. The only summary here you are going to give. All others, what you said, probably will be relevant if you are asked to do that as a long case. Okay?
Yes, sir.
Right. Proceed.
Okay.
What do you think at this point of time, in the history, although you have examined?
Yes, sir.
But at this point of time, a person coming is an adult for what age, you said?
Yes, sir. Adult 40 years, sir.
40 years. Adult 40 years is coming to you with these complaints.
Yes, sir.
Very insidious and going around without any inflammatory signs. Okay?
Yes.
So what should come to your mind?
Sir, I'm thinking the adult 40-year lady, he has the right thigh swelling since last 6 months. There is no history of the trauma and fever and swelling.
What should come to your mind? If you don't
Differential diagnosis, what sir is asking.
Yeah, sir, I'm thinking about it is the mainly swelling arise from the musculoskeletal system of the thigh, sir. Most likely this thing benign or malignant etiology. Most likely malignant etiology, sir.
Why you want to say malignancy at this history itself?
Yes, sir, because of the she giving the short history, 6 months. Usually in the benign condition history in the years she will gives, and it is associated with the mild pain also, so it favoring more in the malignancy.
Okay. Carry on with your findings. With the examination. Carry on with the examination.
Yes, sir. General examination. I examined the patient with taking the verbal consent in the presence of the female staffs. So on the general examination, patient is the conscious, cooperative and well-oriented to the time-place person. BMI is the 26. Patient is the afebrile and pulse 76 per minute regular. Blood pressure 130/70 mmHg in the right arm in the supine position. Respiratory system air entry clear, bilaterally equal, no added sounds, and CBS S1 S2 present. There is no cyanosis, no pallor, cyanosis, clubbing, icterus, and no general lymphadenopathy. Local examination. Sir, I have this clinical photograph that is not. Ideally, the clinical photograph should be including the both limb and one joint above and below the swelling, but I have this.
No, that's okay. That's okay. Being a lady, etc., we understand. Proceed with the examination.
Okay, so on inspection, I examined the both side of both lower limb with fully exposed. On the movement, see the gait is the normal, left lower limb is the normal. On the right lower limb, there is a single swelling, oval shaped, located at anterolateral aspect of proximal and mid thigh, that approx 5 cm below the anterior superior iliac spine and approx 15 cm above the superior lateral aspect of the patella, sir. There is a border not well defined. Surface is the smooth, sir. There is on the skin there is a small biopsy scar present in the center of the swelling, sir. Otherwise, no sign of inflammation, no sinus, no dilated vein, and distal to the swelling there is no muscle bursting and no edema. On palpation, there is no local rate, temperature and tenderness. I confirmed my finding of the inspection. There is a single approx 17 into 10 centimeter side swelling at 5 centimeter below anterior superior iliac spine and 15 centimeter superior lateral margin to the patella. And border are indistinct, surface is smooth, consistency uniformly firm. Swelling is the mobile along the perpendicular axis of when the muscle is the relaxed, and it not fixed to the overlying skin and underlying the bone, and no regional lymphadenopathy. And on neurovascular examination,
No, 1 minute. About the swelling, what is the plane of the swelling now?
Yeah, Sir, plane is the sir. This swelling is the mobile, sir. So it usually and not fixed to the skin. So it the mostly sir intramuscular swelling below the deep fascia, sir, because of it moving this perpendicular to the long axis of the muscle, sir.
No, once it is mobile, you know it is not bone. I understand.
Yes, sir. Yes.
So now remaining part of it, how will you say it is from what level? That's the most important point in this case, no? Such a big swelling in the beginning, in a inspection, it could have been bone, it could have been muscle, it could have been any other soft tissue. But here, once it is mobile, you are talking. So obviously, so really mobile, then it is not fixed to the bone or from the bone. So what is the plane of the swelling? Which level or plane it is coming from?
So plane of the swelling is the intermuscular plane, because of the when I told you that toward the muscle swelling is the more prominent, sir.
So which muscle is involved? You think in which compartment it is?
Sir, this is basically anterior compartment, sir. It mainly the this thing vastus lateralis and this thing, sir, TFL or
TFL.
Sir, TFL basically below the TFL basically just in between the iliotibial tract and vastus lateralis.
When you drop a straight line from anterior superior spine
Yes,
towards the
sir.
side, where is this?
Yes.
This swelling.
Yeah, sir, when I draw the one straight line from the ASIS to the lateral aspect of the superior lateral knee, maximum 60 to 70% portion is the to the medial to the this thing, sir.
Okay, you know why I asked that question? It is to do with the tensor fascial anatomy. So tensor fascial is a muscle, thin muscle. Because you said TFL, I asked that question. That is coming lateral to the anterior superior spine. That what the imaginary line which we talked about. It is lateral to that, not medial to that. This is more in the anterior compartment and more.
More in the anterior compartment, sir.
Yeah. So what are the muscles you think would have got involved now in this if it is coming from the muscle?
Sir, vastus lateralis, intermedius, and rectus femoris.
You said the knee movements are normal. So
Yes, sir.
So knee movement should be normal if rectus femoris is involved, or it should be restricted here.
Sir,
so which muscles help for knee flexion and extension?
Yes, sir. Yes, sir. Sir, most likely that swelling will be located in the intermuscular plane, sir, not involving the full muscle. So maybe knee and hip joint movements are normal, sir.
Yeah. Now come to consistency.
Yes, sir.
See, in a clinical examination, remember, you would have seen the case, you would have worked up, all that are different. But when it comes to clinical examination, one is you are dependent on history, and next is physical findings. We are now sitting with the physical finding. In a physical findings, the swelling like this, obvious swelling in the thigh, only two things are going to be important for us. Is it not?
Yes.
The plane of the swelling. Where is it arising from anatomically? That's what we are talking. The second one is the consistency. Why consistency is important clinically? In this case particularly.
Sir, consistency in the included, suppose that if patient having the previous history of the trauma or this thing, then maybe...
No. Consistency many times will tell you the pathology.
So it's firm, hard, variegated, variable consistency, what sir wants to ask.
Please understand, when you are talking clinical
Yes,
examination, when you are talking clinical, you talk. As we are talking about plane of the swelling is important, now we are coming to the consistency. Why consistency is important? It will tell us.
Yes, sir.
Clinically,
because sir, if soft to the firm, then maybe consistency is the like lipoma or benign etiology, and firm to the hard is the more in favor into the malignant etiology.
So consistency will give us clinical clue regarding the pathology. That is whether it is neoplastic, inflammatory, etc. All right.
Yes.
That is why consistency is important. Remember, in a clinical examination you do, although ultimately we are going to do imaging, we have to prove all that stuff is true. But when you go step by step, clinical thinking should go in a proper and appropriate way, the route. Right? That's where you are talking about consistency, etc. All right. So consistency is required to know clinically what we are thinking. Is it inflammatory, non-inflammatory? If it is non-inflammatory, is it neoplastic or non-neoplastic? If it is neoplasm, are we thinking of malignancy or benign? That's how you take it on clinical findings. Okay? Right.
Yes.
Continue.
And power is the 5/5 in the both lower limb. Sensation in the both lower limb is the normal, and bilateral femoral pulse and dorsalis pedalis pulsation are the normally felt. So summarize, sir. There is the 40-year female present with the progressive increasing size, single firm smooth swelling in the right anterolateral aspect of the proximal and mid thigh since 6 months with indistinct border without fixation to the overlying skin and underlying bone and regional lymphadenopathy, and swelling was associated with the mild leg pain since 1 month. So my provisional diagnosis is the soft tissue tumor of the right anterolateral thigh, most likely malignant.
So what points favor here towards malignancy on your history and clinical examination?
Yeah, sir. One is the duration of the swelling. It is the short history, approx 6 months.
That is based on your history. On clinical examination, any positive point which favors more towards the malignancy, you think?
Yeah, sir. One is the size. Another is the
consistency. It can be a lipoma or any benign tumor which can be of a big size.
But sir,
size is not a criteria to say it's malignant. Any other things you think?
And sir, pains, but size and sir correlating according to the history also. If the shorter history, size is the this much, and with the pain, sir, that mild leg pain. These are the three features, and along with the consistency, the firm to hard consistency, sir. Firm consistency, basically an indistinct border.
So borders are distinct. So you think benign tumor, malignant tumors have distinct borders, very firm.
So malignant, sir, not sir, indistinct border. Border are not clearly well defined.
You said distinct borders or indistinct borders? Indistinct borders. Indistinct borders.
Yes, sir. So then, sir, on the history is the duration, on the examination is the size, or with consistency, firm, and indistinct border, and with the mild this leg pain. These are the favor in the malignancy, sir.
So any differential diagnosis you would like to give based on our age and the location? Which tumors are common in this age group? Soft tissue tumors.
In the soft tissue tumors and this age group, thighs are most common is the liposarcomas.
So 1, 2, 3, if you want to say, so this is one specific tumor. Any other differentiation?
Other differentiation is the synovial sarcoma, sir. But synovial sarcoma.
That takes us to the next level of questioning. Do you think that this sort of differentiation in the by pathology is really required?
No,
with
sir.
With the present day knowledge, is this required, or can we simply say a soft tissue sarcoma? If that is enough? What
no,
do you
sir.
think?
Soft tissue sarcoma, that's enough for the this thing. But for the planning treatment, we need further investigations.
That's what I'm asking. Do you think at this point of time, saying it is as a cocktail and say it is soft tissue sarcoma, is this sufficient, or are you interested in differentiating them into, say, as you are talking, liposarcoma, synovial sarcoma? Does it make any difference in this?
No, sir. No, sir.
No,
yes, sir. It will not make a great difference.
It will not make. Are you sure?
Yes, sir.
Right. I say it's rhabdomyosarcoma. Now tell me, will it make a difference when it comes to, say, liposarcoma?
Then also, sir, same, sir. Rhabdomyosarcoma.
When you say rhabdomyosarcoma or when I say liposarcoma, both you are going to treat in the same way? Is that what you're trying to tell me?
Sir, I'm not sure about the rhabdomyosarcoma, but for the synovial sarcoma and the liposarcoma, I'm going to the same.
Why I specifically said rhabdomyosarcoma, I think?
Sir,
what is the basically the pathology type it will fall into? Rhabdomyosarcoma when compared to, say, well-differentiated liposarcoma?
Sir, well-differentiated liposarcoma. Liposarcoma either well-differentiated, myxoid or round cell or pleomorphic. And rhabdomyosarcoma, sir, that embryonal type, another pleomorphic, and one more, sir, that third one. So embryonal and common in the
No, it matters a little at least because well-differentiated liposarcoma will turn out to be a low-grade sarcoma. Okay?
Yes. Yes.
Whereas when I say rhabdomyosarcoma, you should always think it is probably a high-grade tumor. That is the first thing should come to your mind. Number two, liposarcoma is not going to be considered, though there are types, subtypes, we are going to call them ultimately as all spindle cell tumors. Whereas rhabdomyosarcoma, in principle, we may call it as round cell tumor. This makes a difference in the management. As we go, we'll see. That is why I asked that question. When you say soft tissue sarcoma, is that sufficient, or we have to think of the subtypes also, at least to that extent, whether we are with respect to management. Okay, you proceed. You proceed. How will you proceed now? You tell.
Okay, then, sir. Yes, sir. I will proceed the patient first to investigation to support and confirm my diagnosis. For the investigation, I will go to the MRI thigh, sir.
See, yes. This is the soft tissue sarcoma you have told.
Yes, sir.
When I say proceed, what will you answer me?
Sir,
you proceed to do what? A, B, C, what? What is working in your mind?
Yes, sir. In the soft tissue sarcoma, sir, I will go for the investigation to support and confirm my diagnosis, sir.
Yes.
First investigation is the
correct. One is you have to prove your diagnosis. Correct. Then
yes,
what?
Sir.
Then what?
Then after the confirmation of the diagnosis, I would go for the investigation to stage the disease.
Yes. Then correct.
On the basis if the stage disease it's showing the operable or resectable, and along with I will also go the routine investigation. If on the basis of the staging workup, it is that workup suggestive of the operable, then I will go for the surgery, sir.
See, 3 sets of investigation should come to your mind all the time in cancer if you are making a clinical diagnosis. One, yes, as you said rightly, the investigation is to prove the diagnosis. Next is to stage the disease. 3 is for treatment purposes. Irrespective of what you are going to treat, after the staging, you will know what you are planning to treat. So you will have to investigate to treat the patient as a whole, yes, correct? That yes, is how your compartmentalization should come in your thinking. To prove the diagnosis, to stage the disease, and to treat the patient. Now to prove the diagnosis, what will you do?
Okay. So then first, sir, I did this thing MRI, sir. MRI right thigh, sir.
Right. Tell me. Before we discuss MRI, why only MRI?
Do you require X-ray in this case, Devraj?
Yes, sir.
X-ray of the thigh and the hip and the knee joint you require here?
I will require, sir, X-ray of the thigh, but on the clinically examination, it most likely suggestive of soft tissue. So that I will prefer on the clinical examination it is suggestive of the bone, it originating from bone, then I will go for X-ray first.
It is a basic investigation. You can start with what sir said, Vijay Kumar sir said. So you start with the investigation, which is very basic first. So you get an X-ray done. See the X-ray, what you do in your routine practice in your hospital. So always you order for an X-ray. You order for a basic blood test. So what basic blood test you think here required?
So basic blood test, I will require that CBC, RFT, LFT, serology.
Yeah. Any extra other marker for tumors you have? Soft tissue tumors, any markers?
Sir, there is no marker, but ESR I will along with add, sir. ESR and alkaline
infection. Any other marker?
Alkaline phosphatase and.
Is there any role of LDH here?
LDH, yeah. Sir, LDH, here is the node. If that tumor arising from the bone, then LDH level is the high, sir.
Soft tissue, there is no role of LDH?
Soft tissue, sir, I'm not aware about it.
So LDH can be a surrogate marker for your tumors that if it increases in future for recurrences and other purpose, it will be a useful marker. So start with X-ray, basic blood test, and next MRI will be required. So what is the purpose of getting an MRI here, not CT scan of the thigh? You require MRI or CT scan here?
MRI, sir, because sir, MRI is tell better soft tissue delineation, and MRI will tell the good relationship to the neurovascular bundle as compared to the CT scan, and
so before MRI, you require you can do biopsy or you do biopsy after MRI. What is your protocol? You think?
I will. Our protocol is the first we will do the MRI, then biopsy, sir.
So what is the purpose of this?
Because sir, MRI will tell exactly the exactly lesion where is the located, and sometimes our MRI also tell the where is the site to be the biopsy taken. If we will take the biopsy prior to the MRI, then it will alter the thing MRI. So
which type of biopsy you think you are required? Open biopsy, needle biopsy, core biopsy.
Core biopsy.
Image guided, USG guided, or?
Sir, if image guided is available, then USC guided, USC image guided.
So you can read the MRI for us. What are the findings? Does it confirm your diagnosis? It's arising from intermuscular plane, or what area you are suspecting, or it's different from what you are suspecting?
Yes, sir. It is supporting, sir. This is the T2 patent, sir, axial cut of the right thigh. It is the showing, sir, heterogeneous hyperintense lesion in the right anterolateral aspect of the thigh. That lesion is the quite away from the neurovascular bundle and femur, sir. So just here, sir, we can see this is the vastus in the next coronal section, sir. On the coronal section, we can see, sir, this is the mostly vastus lateralis, maybe, sir, vastus lateralis, or here is the intermediate, sir. Exactly, I can't.
So, do you think your bone is involved? It's quite near to the bone.
Yeah, no, but bone is free because of the in bone and lesion. There is the intermuscular one is the muscle, sir, that vastus intermedialis muscle, that is the that abutting the muscle, but it is not involving the bones.
It is not involving the bone, fine. Suppose if it is so close and you think that the periosteum may be involved, will it make anything on the table?
Surgical plan will change. What sir wants to ask?
Yes, sir. Surgical plan will change because of it abutting the bone. Then we resect the tumor along with the periosteum, sir, and or also that. Reconstruction plan depend on the how much amount of the periosteum has been resected.
Periosteum resection is going to change your plan of reconstruction.
Sir,
is that what you're telling? Is that what you're telling? Hello?
Because, sir, yes, sir. Sir, if we remove the more than 50% circumference of periosteum of the full bone, then it's required some prophylactic fixations.
Dr. Adjuvant?
Yes, sir. Theoretically, it's said but not done so commonly.
Oh.
As a nailing, if you use a post-op radiation, there are chances of pathological fracture. So it is said that you can nail the bone, but not done that commonly, sir.
Yeah. See, we don't do that so very commonly. That's why I asked.
Yes, sir. It's not done commonly, sir. Not done commonly.
Although we are removing one part of the periosteum if it is necessary, we don't do that anything.
It doesn't affect that much strength of the bone, so not leading to high chances of fracture. So,
correct.
Can be avoided, sir.
Right. Continue.
Okay, sir. So after the imaging, sir, on the imaging finding, there is the
neurovascular bundle. You think it's free here? Just go to the previous image.
Yeah, sir. Because neurovascular bundle also quite away, sir. It's free, sir.
So from which approach you will take the biopsy? Anterior, anterolateral, anteromedial. And what is your final line of incision you think here?
Sir, my incision is the anterolateral, sir.
And what muscles will be resected, or what things you want to intend to resect in your final surgical plan based on your MRI?
My final surgical plan is the, sir, bite local excision with the taking the 1 centimeter margin, sir.
1 centimeter margin. Is that sufficient, you think, for all types of tumor as on today? What is the recommendation? Will it change with the subtypes at least?
Yeah, sir. It will change along the according to the subtype. It's suppose that on the biopsy is the well differentiated liposarcoma, then less than 1 centimeter margin we can consider enough. But is the on the biopsy it is the dermatofibrosarcoma or myxofibroblastic tumor, myxofibroblastic sarcoma, then 2 centimeter margin to be required, sir.
Basically, we are more often we are more worried about grading also. Low-grade tumors, what is the type of, how much clearance is enough? And you think high-grade tumors, what will be the clearance required?
Sir, for the low-grade tumor is the less than 1 centimeter is the suffice, but for the high-grade tumor is the 1 centimeter margin is the minimum required.
In practice, you are going to give only 1 centimeter?
No, sir.
Even with high-grade tumor, are you going to give only 1 centimeter? 1 centimeter margin is minimum what is required, but while you are operating, you will be stretching, pushing, pulling, etc. So what will happen technically?
Yeah, so on the operating, sir, we will go more wide, but 1 centimeter on the final pathological.
It is the pathologist is going to look at it by the time it would have shrunken, etc., etc. Okay?
Yeah.
But while operating on the table, we will be pulling, pushing, etc., the muscle stretching. So, and also patient is under anesthesia. So, we will be giving more than 1 centimeter. Why I said that to you people is, what the pathologists expect is minimum of 1 centimeter is after removing, the tumor will, the specimen will shrink, muscle will shrink, all that. With that itself, they require minimum of 1 centimeter and more. So, that is the point. So, on the table, you will always try to get more. Minimum 2 centimeters or so will try to give on the table, so that pathologist wise you will at least give 1 centimeter margin. Okay?
Yes.
When you are talking about this, this is a thigh. I want, for the sake of discussion, I am asking, what is compartment dissection or group excision?
Sir, in the compartment.
No. What is compartment excision? I am asking.
So in the compartment, we will remove the full compartment. Like in the thigh, there are three compartments, sir: anterior, medial, and lateral. On the compartment resection, we remove the one compartment, sir.
Meaning what? Okay.
Meaning, sir, this thing.
Okay, I'll ask the other way. What is group excision? Group excision.
We remove the full one compartment along with the full muscle.
Full compartment
from origin to
insertion. Full compartment means what? That's what I'm pretty clear.
Sir, origin to insertion of the dead, all muscles of the dead compartment.
Origin to insertion, and that compartment muscles are removed. That is what is called as compartment excision and then group excision.
So how many compartments you said, Dr. Devraj?
So 3 compartments.
Yeah. What are the 3 compartments?
Anterior, medial, and lateral, sir.
Is there a lateral compartment or there is a posterior compartment?
Sorry, sir. Anterior, medial, and posterior. Sorry.
So you need to know the muscles. So which are the muscles here?
Sir, in the anterior compartment are the sartorius and rectus femoris that have the 4 parts, sir. Quadriceps femoris that have the 4 parts: rectus femoris, vastus lateralis, vastus intermedialis, and vastus medialis, sir.
So sir said compartment excision. So which compartment excision will be required if is required here?
Anterior compartment, sir.
What is the disadvantage of doing the compartment excision and what is the advantage of doing compartment excision?
So advantage of the compartment resection, basically principle of the compartment resection to remove the skip lesions, sir. If we will do the compartment resection, there is we can avoid the radiation, sir, adjuvant radiations, because we are removing the skip lesions, sir.
To avoid radiotherapy is not the point at all. Radiotherapy will come to that. Indications are not necessarily cut margin alone. No, it is something more also. We'll come to that. But the advantage is that what you said is correct, that you are going to remove the whole of the group of muscles where the skip lesions, if they are there, or satellite lesions can be removed. That is the advantage. Completely you are going to remove. What is the disadvantage?
So disadvantage is the morbidity because we are removing the one compartment, so the muscles of that compartment we are losing, so that related morbidity is there.
Anything else? If the radiotherapy is required based on other parameters which we'll talk, say grade, size, etc., are also there which are going to make post-operative radiotherapy indication. So you have removed now the compartment from origin to incision, and the incision is so long, and when you give post-operative radiotherapy, literally the whole of the bone will get radiotherapy. You got what I'm telling?
Yes, sir.
Literally
Yes,
the
sir.
whole of the bone will get radiotherapy. One.
Yes.
And two, if it is a large excision and they give radiotherapy, there is going to be cutaneous edema, full circumference, and severe lymphedema of the arm. Lower limb will occur post-RT. So post-RT edema will be an issue. The whole bone will be getting exposed to radiotherapy is another issue. So in any way, it is not going to increase what? Increase what? Ultimately, there are two things we are going to look at it in cancer clearance. One, overall survival. Another is disease-free survival. Here, we are talking about local recurrence rates. Okay, so now we'll come to the local recurrence. What are the different types of surgery you can offer in theoretically? We'll come 1, 2, 3. Tell me. Now we have discussed about group excision and compartment excision, and you have been talking about wide excision, how much clearance you told. What are the other types of excisions available, surgical excisions?
Another type is one is the intralesional resection, another is the marginal resection, sir.
Right. Intralesional excision, is it a done thing in soft tissue sarcoma? If it is done, what is it called?
Enucleation?
No. Is it a therapy, I'm asking? Is it therapeutic?
No, sir. No.
Try to do that. Is it therapeutic?
No, sir.
Intralesional excision is considered only as a biopsy procedure. By whatever reason, for example, you thought it was benign and you removed it, and then pathology comes as a surprise, but you have removed it already. It has to be considered as a biopsy, not as a therapeutic procedure. That is what is important as far as intralesional excision is coming. Next is marginal excision. What is marginal excision?
So marginal excision, we will resect the tumor in the reactive zone, that reactive zone surrounding the lesions.
How do you know it is reactive zone, etc.? They are operating.
Sir, there is the edema in the peri surrounding the tissue.
You should not see the tumor. You will a few millimeters of soft tissue will be normal tissue will be around it, and you will be removing it, and that is called as marginal excision. If you do intralesional excision, what will be the recurrence rate you think? For discussion purpose, I am asking. Already I told it cannot be called as therapeutic procedure. By chance, by mistake, or do whatever it is, you just leave it. If the patient says already that surgery, what will happen to the recurrence?
So recurrence after the intralesional resection, sir, exactly I am not aware about.
100%.
100%.
That is why we are telling not to do. Once you go through the reactive zone and then remove it, there is no capsule, is it not so? It's only a pseudo capsule created by the transition zone. So through the pseudo capsule, if you go and remove it, it's called as intralesional, and naturally you are leaving behind disease microscopic at least. So the local recurrence rate is around 100%, and that's why we don't accept it as a therapeutic procedure. Now marginal excision is now you are told. If you do marginal excision, what will be the recurrence rate? Only marginal excision. You don't do anything else. No RT, no chemo. If you do that, what will be the recurrence rate?
Approx 50 to 60%.
It is 90%. 90% will be the recurrence rate. Then comes wide excision. If you do only wide excision, don't do anything, what will be the recurrence rate?
Sir, 20 to 30%.
50%. 50% will be the recurrence rate, depending on, of course, grade, etc., etc. But wide excision alone you do, it will become 50%. You do only compartment excision or group excision, what will be there? Don't add anything else. What will be the recurrence rate?
Sir, up to 5%.
It is 15%. So it is 100%, 90%, 50%, 15%, 1/5. Nothing with surgery alone. We are mixing everything, meaning low grade, high grade, everything. I'm just giving what is quoted recurrence rate.
Yes.
Where I am coming now is, so the compartment excision, if you look at surgery alone, will be the best local recurrence rate of 15%, whereas if you do wide excision only, you are going to do 50%. Well, the recurrence rate will be 50%. In that situation, why you are now choosing, I'm coming to what you said, wide excision over compartment excision? Recurrence rate is more. Is it
because
not?
sir, just wide excision over the compartment, because overall survival is the nearly same, sir. If in the wide excision, we will give the adjuvant treatment, sir.
That's not the way we are looking at. Our idea is local recurrence rate, how to reduce it. So wide excision plus radiotherapy
Yes.
is the best of the local recurrence rate with least of the morbidity. The morbidity of compartment excision is not there. And hence today we try to tell wide excision plus radiotherapy. Where are radiotherapy given, not where we will not give at all, we'll talk. But in principle, wide excision plus radiotherapy gives the best of the local recurrence control. And
Yes,
hence we are telling wide excision is the treatment of choice. You got what I am coming to? Although surgery alone, you look at it, compartment excision gives the best local control. We don't prefer that because of the morbidity, etc. Whereas the similar results we can get by adding radiotherapy to the wide excision if needed. Okay, that is why we are looking at wide excision as the treatment of choice.
What was your histopath in this case, Dr. Devraj?
Histopath on this biopsy is this thing, sir. High grade myxoid liposarcoma.
So what is the next investigation you'd like to do? You are confirmed with the biopsy reports.
Yeah, next investigation, sir. I did this thing, CT scan thorax. That also normal, sir.
Any role of abdomen, pelvis, CT scan you think here? Lymph node mets are common in these tumors?
In liposarcoma, it's not, sir. Other variant, there is a lymph node.
Which tumors you think are commonly metastasizing to lymph nodes? Which?
Synovial sarcoma, clear cell sarcoma, and rhabdomyosarcoma, epithelioid sarcoma.
So in these tumors, you should get a CT scan done of the abdomen, pelvis. Any role of PET scan here in this case?
Sir, in this case, no, sir. If, sir, we are planning for the neoadjuvant, then for the response assessment, can consider for the PET, sir.
So these tumors require neoadjuvant chemo, or you can proceed directly with surgery?
Sir, because on the MRI imaging, it looking the resectable, so as our hospital protocol, we underwent for the surgery. But
which type of liposarcomas require neoadjuvant chemotherapy, you think?
Sir, myxoid round cell more than 10 centimeter, but very close to the neurovascular bundle. So they may.
Here it's more than 10 centimeter. You are saying it's myxoid.
Yeah.
Role of chemotherapy before surgery?
Yes, sir. Yes, sir. If the high grade more than 10 centimeter liposarcoma very close to the neurovascular bundle, we feel we can't resect without compromising the neurovascular bundle.
Any role of pre-op here?
No, sir. So
is it tried or not recommended in any case in soft tissue sarcomas?
Sir, in some studies are tried for the retroperitoneal sarcoma, but very limited data available for the extremity sarcomas.
So what is the advantage of pre-op if given here?
Sir, if we will give the pre-op advantage is that radiation field is the less, sir, and acute toxicity are the less, like fibrosis, edema, and acute post-operative wound complication are the less. If we are any higher in the
more in complications are more.
Yeah, wound complication is the more, but radiation, fibrosis, and radiation field is the less in the pre-op RT, sir. And one study
barrier concept in surgical margins. Barrier concept. What sir was 1 centimeter, 2 centimeter?
Yes, sir. Barrier concept.
What is the concept of that barrier concept?
Barrier concept is the Kawaguchi concept, sir. It's the thick barrier or thin barrier, sir. And thin barriers are the in adult periosteum, muscle fascia, epineurium, and basal sheath, sir. And thick barrier.
What barrier you require here in this case?
Sir, here is the fascia we require. Muscle fascia.
No. MRI you saw.
Yes,
it was almost lying over the periosteum. That's where we discussed about periosteum, etc.
Yes, sir.
Do you think that there we will have problem? Problem means we may have to strip the periosteum or not? We may have to, no?
No, sir, it is located in the intermuscular plane, sir, because in periosteum and lesion there is the one muscle also, so no need to the stripping of periosteum, sir.
I am not telling you should remove periosteum as a whole. When the third dimension, we are not able to get 1 centimeter margin, it is lying over the periosteum. Will you leave the periosteum or remove the periosteum? When it is involved removing, we are not at all talking there. We are not talking about periosteum involvement. We are talking about it is close proximity. Will you remove? Not remove.
In this case, what sir is asking.
Yeah, we will remove.
Quite close there. On MRI, you have seen only 2 MRI images. You need to see all the images.
Yes, sir. Yes,
you can do CT scan of the thigh to know the close proximity to the bone also. That can also be done.
Yes, sir.
So intraoperatively, what precautions should be taken here in this case? If you're operating, it's a biopsy-proven now sarcoma, non-metastatic. Your plan for surgery, you not to counsel the relatives. What sir said, recurrence rates and other things. So how you counsel the patients in your clinics? What things you counsel them about anesthesia risk and all other risks? How you counsel them? And what important things should be anticipated here in this case?
Sir, I will tell about the recurrence rate, sir, and regarding the adjuvant treatment, sir, what to be required, and follow-up.
Functional deficit in this case, any you think occur after removing the muscles that you need to counsel? Any chances of amputation intraoperatively, you think?
No, sir, no.
No. Nerve damage, you think any closed nerves here?
No, sir.
So which nerves are here in this part of the leg, you think? Anteriorly, which nerves are common?
Femoral.
Femoral nerve is there. And posteriorly?
Posteriorly sciatic.
So you think that are close to these tumors or quite away?
It's looking away, sir, but we need to discuss with the radiologist in the console if any the suspicion.
No, you need to read yourself, no? What is the location of the nerve? You are the operating surgeon, radiologist will not come for us in OT.
Yeah, sir, in our imaging, it looking quite away from the needle.
So any other complications you anticipate post-operatively? It's quite big thigh swelling.
Yes, sir, seroma, I will explain the patient about this.
So 1 drain or 2 drains you will put here?
Sir, I will put only 1 drain that more close to the skin.
So which part of the incision you place the drain? Along the line of incision or away from the incision?
Along the line of incision, but not away, just nearby.
So what is the significance of that, putting a drain in the line of incision?
Because, sir, we are taking in the radiation field, adjuvant radiation field, or in the final pathology, if there is a positive margin, then we will resect that along with in the.
And what is
that you said? Margins? What did you say?
So the drain for the drain side, it is the near close to the incision margin, and my aim is it should include into the post-op adjuvant radiation field if required, sir.
Okay. You are talking about incision and the drain site you asked. So margin, you use the word margin, so I asked what it is. Okay, right, continue. What are the indications for post-op party? You are not given anyway pre-op party.
Yes,
you said we don't give pre-op party, but it's operable in our institution. You go and remove it. You said fine. The pathology, final pathology report comes as so-and-so size. Grade is high grade. And cut margin is more than 1 centimeter. Then what will you do? High grade is anti-size. These two are otherwise to be taken.
Sir, yeah. So, sir, then any high-grade tumor are the indication for the adjuvant radiation, and any more than 5 centimeter, except well differentiated, and close or positive margin, sir, less than 1 centimeter. These are the indication for the adjuvant radiation.
See, here it is high grade.
In case of the well differentiated liposarcoma.
1 minute. This is high grade. You also said what it is. Then comes size. Size also you know. MRI is showing you clinical also know the size. So once you know the size as MRI as well as clinical, and you are now know the grade, high grade, is there a role for RT or not?
Yes, sir. It's all for RT, sir. Adjuvant RT.
So, it is more than 10 centimeters, you will give post-operative RT. When will you not give RT post-operative?
Sir, if even less than 5 centimeter, but low grade, sir, low grade or band differentiated liposarcoma, and even 5 to 10 centimeter or less than 10 centimeter, we will not give the adjuvant RTs.
What is the type of RT you would like to give? To give post-op RT?
Sir, in this case, I will advise for the external beam radiation along with the brachyradiotherapy, sir.
Brachy is required.
Yes, sir, because of the more than 10 centimeter and high grade, sir.
So you cannot cover it with only external beam RT. You have to give brachytherapy. Brachytherapy.
Sir,
what I am asking is, I am not telling brachytherapy should not be given. Is brachytherapy mandatory, or we can do it along with the external beam radiotherapy with a boost with radiotherapy with external beam only? Can it be done? I am asking.
Sir, because high grade and more than 10 centimeters, so external beam radiation along with the brachytherapy boost is required, sir.
External beam radiotherapy is good enough to give up to 50 gray, and then we can add even 10 to 20 gray, even with the boost with external beam radiotherapy. It is possible. But at the same time, the brachytherapy, when will you give brachytherapy, when will you not give brachytherapy? Tell me. When in other words, brachytherapy is really mandatory.
Yeah. So brachytherapy when this thing more than 10 centimeter, high grade and closed margin cells.
So all tumors majority of tumors are high grade, more than 10 centimeters. So you do give brachytherapy in all cases you perform? So what are cases of soft tissue you have seen in your last 3 years? You are giving brachytherapy in all cases, or there are specific indications what sir is asking?
Sir, closed margin cells.
Close can be, it's not an indication. You need to tell exact indications of brachytherapy. How many you have seen until now, brachytherapy cases?
So along with the boost, sir, brachytherapy as a boost, or sir, on the brachytherapy?
Operatively, you have put the brachytherapy wires and everything. How many cases you have done or seen?
No, sir, I did not see.
So why it was not done? Or
that is the point.
I want to ask, no.
We are repeatedly
telling you anything, you should justify your answer. In exam, it's very important. The examiner will ask you what is brachytherapy, what are the indications, how it is done, how the beads are placed. Then you should know all the steps. Intraoperatively, how it is done. Postoperatively, on which day the radiation is given. What are the advantages of brachytherapy or other types of radiation? So if you are commenting on any part in exam, you should know that part in detail.
Yeah, sir. Post-operatively on the post of day 6, usually we start the brachytherapy. On brachytherapy wires, we will place either on the incision that perpendicular to the incision side, usually 1.5 the parallel and this thing, and all are the wire are the parallel to each other, sir. They will cover.
Vessel should be closed or away from the tumor. You need to cover the vessels.
Yeah, vessels should be covered with the muscle or flaps, sir.
Nerves should be away.
Yeah, nerve and bone, all of that should be covered with the muscles or flaps, sir.
So any role of post of chemo in this case?
Yes, sir. This is the high grade and chemosensitive tumor, so it required the adjuvant chemotherapy also, sir.
So you require adjuvant chemo and RT both in this case?
Yes, sir.
So how you space them? How means you give first chemo, first RT, second chemo?
First I will give the chemotherapy, then
What are the type of chemotherapy you are using in your setup? You tell me, then we'll come to others. Chemotherapy, post-operative.
Chemotherapy regime, sir, you are asking about?
Yes, what are the drugs I'm asking?
Sir, in the adriamycin, doxorubicin and mesna, sir.
Adriamycin, doxorubicin are one and the same day.
Sorry, sir. Adriamycin, efosfamide and mesna.
Okay, that is called AIM. Okay. What is the dose? What is the dose of doxorubicin used here?
Adriamycin is the 20 mg per meter square. Ifosfamide is the 1.5 gram per meter square, sir.
What is mesna?
Mesna is the, sir, it is the basically using the, because of the agent for the ifosfamide, it is causing the hemorrhagic cystitis. So
one line answer, it is uroprotectant.
Yeah,
uroprotectant. Ifosfamide causes cystitis, so you give mesna, and that is a uroprotectant.
Yes.
So mesna is not the drug for treating, but it is to protect the side effects. Okay, it is basically doxorubicin and ifosfamide. Any other regime you know of?
Sir, any other regime, sir? One is the MAID, sir. That mesna, ifosfamide, adriamycin, and D4, dicarbazine.
DPIC or doxorubicin, one of the two. They both are same. Doxorubicin.
Yes, sir.
D is doxorubicin. Okay.
Yes.
Now, what are the new drugs that have come in a South Asian sarcoma? I'm not talking about chemo. Any new drugs have come like monoclonal antibodies or targeted therapies that have come?
Maybe come, sir, but sir, I'm not aware about that.
Fine. Very good, you are not aware. Right. Now comes this, coming back to this case. Do you think this patient after surgery, how will you rehabilitate? Or when will you start rehabilitating?
Mobilization of the patient. What sir wants to ask. Post-operatively, what hip movement, knee movement, walking with walker, without walker?
Yeah. Sir, knee movement and hip movement we will start on the day one only, sir. But on the
Day one is very painful, Dr. Devraj. No one will do on day one. So what do you do for your patients? How you mobilize them? Or if you operated a case of soft tissue tumor around thigh?
Sir,
any role of antithrombotic lytic agents here? Clexano and other things should be given in this case?
Yes, sir. Yes, sir.
40 years patient, aspirin, Clexan.
Yes, sir. Yes, sir. We will, our hospital policy, we will give Clexan for the 5 days, sir.
And how you mobilize it, what sir was asking? The functionally, how you...
Sir, initially for the first 3 days is the passive motion, then we will start the gradually active motions.
So walking with a walker, a stake, or a...
Even first we start with walking with the walker, then independently.
So you give your knee brace to the patient? Knee brace?
No, sir, I am not aware about it.
Remove the muscles, quite around 20-30 centimeters muscles of the thigh and leg are removed. So immobilize the knee for a few days. It will be a good idea for healing or...
Sir, I am not aware of that.
And how you follow this patient? So you have done suture removal after 2 weeks. Then you send it for RT for after how many days then?
Sir, then I will follow for the patient for first 3 years is the 3 to 6 monthly, sir. Then 3 to 5 years is the 6 monthly. After 5 years,
what do you do for these patients on follow-up? Clinical examination, X-ray, MRI, PET scan.
Yeah, sir, I will follow up the patient with the clinical examination. And the first 3 years, in the first 2 years, the 6 monthly, this thing, MRI, thigh and chest X-ray, sir. Then annually, sir. But clinical examination on the every visit, sir.
And what is the prognosis here? You in the 5-year survival of the patient, it's myxoid liposarcoma. The relatives will ask after surgery how much our patient will survive. The patient will ask you. So what do you explain to him?
So 5-year survival rate more than 90%.
For these tumors.
Sir, exactly.
You need to explain. No, you need to explain to the relatives. No, they'll ask the very important question for them. What is the survival?
Sir, if be well confident with the surgery and everything, then survival is quite good. Exactly figures, sir, I'm not aware about.
Oh, you can say it's good, bad.
It's good, sir.
Good, it is good.
Before we conclude, because as far as this case is concerned, we are coming to almost an end. For the sake of all students who are listening to us, please remember there is something more is happening here. at this point may or may not be coming, but we have to know this. That is the molecular classification of the soft tissue sarcoma is coming in a big way, and repeatedly asked in the theory questions as I saw and as I see. So today may or may not be